In this video, we are going to audit a hysterectomy, so audit report 11-1. So let's first read our scenario. Our pre-op, post-op diagnosis is endometrial carcinoma, procedure performed, total laparoscopic hysterectomy with laparoscopic staging, including para-aortic lymphadenectomy, bilateral pelvic and ureter lymphadenectomy, and washings. So our history, our patient was found to have grade 2 endometrial cancer. She was counseled to undergo laparoscopic staging. During the laparoscopy, the uterus was noted to be upper limits of normal size with normal appearing right fallopian tubes and ovaries. No ascites was present. On assessment of the upper abdomen, the stomach, diaphragm, liver, gallbladder, spleen, omentum, and peritoneal surfaces of the bowel were all unremarkable. So the description says, our patient's taken to the OR with an IV line in place, anesthetic was given. She was placed in a low anterior lithotomy position using Allen stirrups. The vaginal portion of the procedure included placement of a Zumi uterine manipulator with a colpotomy ring and vaginal occluder balloon. The laparoscopic port sites were anesthetized with intradermal injection. There were 5 ports placed. The Veress needle was placed through a small incision at the base of the umbilicus, and a pneumoperitoneum was insufflated without difficulty. A 3 mm port was placed in the left subcostal position without difficulty. A 3 mm scope was placed. There were no adhesions underlying the previous vertical midline scar. The 10 mm port was placed in the umbilicus and the laparoscope was inserted. Remaining ports were placed under direct laparoscopic guidance. Washings were obtained from the pelvis and the abdomen was explored with the laparoscope with findings as noted. Attention was then turned to the lymphadenectomy. An incision in the retroperitoneum was made over the right common iliac artery extending up to the aorta to the retroperitoneal duodenum. The lymph node bundle was elevated from the aorta and the anterior vena cava until the retroperitoneal duodenum had been reached. Pedicles were sealed and divided with bipolar cutting forceps. Excellent hemostasis was noted. Boundaries of dissection, including the uterus lateral common iliac arteries and uterine crossover inferiorly, and the retroperitoneal duodenum superiorly, with careful preservation of the inferior mesenteric artery. Right and left pelvic retroperitoneal spaces were then opened by incising lateral and parallel to the infundal pelvic ligament with the bipolar cutting forceps. The retroperitoneal space was then opened and the lymph nodes were dissected, with boundaries of dissection being the bifurcation of the common iliac artery superiorly, the psoas muscle laterally, inguinal ligament inferiorly, and the anterior division of the hypogastric artery medially. The posterior boundary was the obturator nerve, which was carefully identified and preserved bilaterally. The left common iliac lymph node was elevated and removed using the same technique. Attention was then turned to the laparoscopic hysterectomy. The right infundopelvic ligament was divided with the bipolar cutting forceps. The mesovarium was skeletonized. A bladder flap was mobilized by dividing the round ligaments using the bipolar cutting forceps, and the peritoneum of the viscopurian fold was incised to mobilize the bladder. Once the colpotomy ring was skeletonized and in position, the uterine arteries were sealed using the bipolar forceps at the level of the colpotomy ring. The vagina was transected using a monopolar hook, resulting in separation of the uterus and attached tubes and ovaries. The uterus, tubes, and ovaries were then delivered through the vagina, and the pneumo-occluder balloon was reinserted to maintain pneumoperitoneum. The vaginal vault was closed with interrupted figure of 8 stitches of ovicral using the endo-stitch device. The abdomen was irrigated and excellent hemostasis was noted. The insufflation pressure was reduced and no evidence of bleeding was seen. The suprapubic port was then removed and the fascia was closed with a Carter-Thomason device and O-vicryl suture. The remaining ports were removed under direct laparoscopic guidance and the pneumoperitoneum was released. The umbilical port was removed using laparoscopic guidance. The umbilical fascia was closed with an interrupted figure of 8 stitch using 2 O-vicryl. The skin was closed with the interrupted subcuticular stitches using 4O minocal suture. The final sponge, needle, and instrument counts were correct at the completion of the procedure. The patient was awakened and taken to the post-anesthesia care in stable condition. So, it tells us that one or more of the following codes are reported incorrectly for this case. Identify the incorrect code or codes. So the CPT code, it says, is 58548, laparoscopic radical hysterectomy with bilateral total pelvic lymphadenectomy and para-aortic lymph node sampling with removal of tubes and ovaries. And our diagnosis, it says, is cancer of the endometrium, C53.1. So let's go to our coding manuals first. And look at C53.1. So C53.1 says malignant neoplasm of exocervix. And if we look at our scenario, ours was endometrial, not exocervix. So if we go back to our book, malignant neoplasm of the endometrium is right here, C54.1. You could also look that up in the neoplasm table, right? If we went to neoplasms, and once you're at the neoplasm table, we would go to E, endometrium. So, neoplasm and then E is to endometrium, and we're given the C54.1. Now for CPT, it tells us 58548, right? 58548. So get out your CPT manual and flip to 58548. So 58548. Laparoscopy surgical with radical hysterectomy with bilateral total pelvic lymphadenectomy and para-aortic lymph node sampling or biopsy with removal of tube and ovaries. Let me make that bigger. So our uterus was not removed through the scope, right? It was removed vaginally when we read through the report. So we would do the laparoscopy with a vaginal hysterectomy and removal of the tubes and ovaries. And then we would also do the laparoscopy for the pelvic lymphadenectomy. It was bilateral with the peri-aortic lymph node sampling. So those are two different procedures, because if we go back to our scenario, the uterus was removed vaginally. So right here, description of procedure, the second sentence, the vaginal portion of the procedure. So we know there's two different procedures, and then attention was turned, the second paragraph, attention was turned to the lymphadenectomy, an incision was made, the lymph node bundle was elevated, and then the third paragraph, attention was then turned to the laparoscopic hysterectomy. So there's different parts of our procedure, right, that we need to code. So let's go back to our CBT book. And we're going to go to hysterectomy in your index. Okay, hysterectomy. And then if we pick a vaginal, we have all these to look at. So I'm going to give you a minute to look through all of these. We have 58260 to 58270, 58290 to 58294, and 58550 to 58554, and see which one you think is applicable. Okay. Hopefully you came up with 58554, which is laparoscopy surgical with vaginal hysterectomy for uterus greater than 250. The physician documented that the uterus was large. So, and with removal of tubes and ovaries. So we want 58554 for the first part of the procedure. Then we also have to code the lymphadenectomy. So in your index, now let's look up the second one, lymphadenectomy. So the lymphadenectomy was done by the scope, laparoscopy. So go to laparoscopy and then down to lymphadenectomy, which we have one range to look at, 38571 to 38573. So let's flip to those. 38571 is laparoscopy surgical with bilateral total pelvic lymphadenectomy. 38572 is laparoscopy surgical with bilateral total pelvic lymphadenectomy and peri-aortic lymph node sampling, single or multiple. And the last one, laparoscopy surgical with bilateral total pelvic lymphadenectomy and peri-aortic lymph node sampling, peritoneal washings, peritoneal biopsies, omenectomy, and diaphragmatic washings, including diaphragmatic and other serosal biopsies. So if we go back to our scenario, they did total laparoscopy hysterectomy with laparoscopic staging, including para-aortic lymphadenectomy, bilateral pelvic and arburator lymphadenectomy, and washings. So let's look at the actual part where this was done. The second section, the second paragraph, attention was then turned to the lymphadenectomy. An incision in the retroperitoneum was made over the right common iliac artery, extending up the aorta to the retroperitoneal duodenum. The left node bundle was elevated from the aorta and the anterior vena cava until the retroperitoneal duodenum had been reached. Pedicles were sealed and divided with bipolar cutting forceps. Excellent hemostasis was noticed. Boundaries of dissection included the uterus lateral, common iliac arteries at uterine, crossed over inferiorly, and the retroperitoneal duodenum superiorly with careful preservation of the inferior mesenteric artery. Right and left pelvic retroperitoneal spaces were then opened by incising lateral and parallel to the infundopelvic ligament with the bipolar cutting forceps. The retroperitoneal space was then opened and the lymph nodes were dissected, with boundaries of dissection being the bifurcation of the common iliac artery superiorly, psoas muscle laterally, inguinal ligament inferiorly, and the anterior division of the hypogastric artery medially. the posterior boundary was the arbitrator nerve, which was carefully identified and preserved bilaterally. The left common iliac lymph node was elevated and removed using the same technique. So they did a laparoscopy with bilateral total pelvic lymphadenectomy and lymph node sampling. So that would be, if we go back to our CBT book, that would be 38572 with bilateral total pelvic lymphadenectomy and periaortic lymph node sampling biopsy. So our codes for this would be 58554, 38572, and then we're going to put modifier 51 to show it's a multiple procedure, right? And our diagnosis was C54.1. Now, if you want to go to find a code, let's bring that up. We're going to go to tabular. And again, you pick, let's first pick our ICD-10. You can just enter your code right in here to verify or to check if you want. Ours was C54.1. Malignant neoplasm of endometrium. Then if we want to go back to codes, we can do the same for CPT. We want to enter 58548. And go back to codes again. We can enter our second one, which was 38572. And you can see we don't get the same subscription content to read everything that's included in that code like we do with the actual CBT book, because we do not have the complete subscription as part of Find a Code. But if you just want to verify that code, there's that process. Here's the links up here and Find a Code to articles. If we click here to the AMA CBT Assistant, it'll link us out. Tells us what those are.